I like to invite Dr. Rajesh Sinha, who doesn't need any introduction. He is almost there in all mails of AIUS as a treasurer AIUS. But apart from his political designation, he's a prolific cornea surgeon, and we love to hear his talks because it's lucid and is well demonstrated by data and facts. Dr. Rajesh.
Thank you, Dr. Vinender Gupta. And most importantly, I would also like to add one sentence in my introduction that I'm a good friend of Dr. Vinender Gupta. And so thanks for involving me in this instruction course. I'll be talking about gludial with corneal procedures, and I don't have any financial interest. Now, there are certain indications wherein you do have to plan for an IOL, wherein you don't have a support. There's no capsule, nothing. In that case, either you put an anterior chamber IOL, or you do an iris clip lens, iris claw lens, retrofixation, or you do a SF IOL. Now, these things are there. But there are certain conditions wherein you can't even put an anterior chamber IOL, wherein there is a narrow angle, iris badly damaged, and various other scenarios. Patient has to undergo an endothelial keratoplasty in a subsequent stage. So in such cases, you would want an implant to be a little further away from the graft endothelium. And that is why I prefer doing the intrascleral haptic fixation or SFIOL. I've also done sutured IOLs in these cases. I'll come to that in my later slides. So the indications will be aphakia with endothelial decompensation or with corneal scars. If there's a dense scar, then you would like to do a full thickness graft in order to have a better visual outcome. And of course, pseudophakia with corneal decompensation or scar with IOL in unacceptable position. So by IOL in unacceptable position, I mean to say that if it's an PC IOL, sometimes, it is put in the anterior chamber because of the panic, because of whatever reason. We do encounter many cases wherein the patient comes to us with a decompensated cornea with posterior chamber IOL in the anterior chamber, causing recurrent UGH, causing, tilt of the PCIOL, causing touching the peripheral part of the cornea. It's a IOL which is tilted, hanging, all sorts of things, or an AC IOL which is very close to the endothelium, causing decompensation, tilting, having bad synechia. So all these can be considered as IOL in unacceptable position, because the most acceptable position of IOL is in the posterior chamber, wherein it close to the nodal point of the eye, so that not only the refractive outcome is good, but also the distance from the endothelium and every part is in the most physiological aspect. It is in the most physiological relationship, having most physiological relationship with all the structures. So coming to the procedures that we can do, so coming to the options that we can do in cases wherein you have a corneal scar or a corneal decompensation, we can do either ultra-thin DSEK or a DMEC procedure with intrascleral haptic fixation of IOL, or you can do a PK full thickness graft with intrascleral haptic fixation of IOL. So this is just an example of a case wherein ultra-thin DSEK and glue IOL is being done. So the anterior lamella has been cut by a microkeratome, and then the posterior lamella is being fashioned, endothelial with a little bit of stroma. And then this is a case with an endothelial decompensation with IOL in unacceptable position, which is an AC IOL tilted, touching the endothelium. So in that case, the glued IOL is being planned. So normally what I do, I have slightly modified the technique which has been reported earlier. And I make a flap with a dissection adjacent to it, so as to create a groove in the same plane as the base of the scleral bed. So I'll come to that, why I do that and what is the rationale for that. So after doing all these, the Descemet scoring is done, and then the incision is enlarged, and then this the remaining Descemet, whatever is there, is removed, and then after enlarging the incision, the IOL is being removed. This is an AC IOL which was touching the endothelium at some places, and it was very close to the endothelium at some other place. So a stab incision is being placed at the scleral bed, and then a multi-piece IOL is being introduced. Since the incision is large, so I don't have to fold it. Otherwise, if it's a small incision, I will use it an injector. Tip of the haptic is held with a lens fixing forceps, and then it's exteriorized. And then the second tip is also exteriorized on to the other side. And once both the tips are exteriorized, it is tucked into the groove. Now, this groove is on the same plane as the scleral bed. So there's no bending, number one. Number two, the haptic follows its curve. So I don't create a chariot pocket. I create this adjacent groove with the dissection with the crescent blade. And this I had reported in Journal of Cataract and Refractive Surgery, which was published. So after fixing the lens, the endothelial tissue, the lenticule, is loaded on the Busen glide, and then it is introduced into the anterior chamber, and then air is injected to push this tissue against the stroma of the host, and then that is the end of the procedure. Now, what I wanted to tell you, not creating the chariot pocket and dissecting with a scleral, with the crescent blade, the ease, first of all, it is very easy to do it. Number two, when you are creating a chariot pocket, although it doesn't make a clinical difference, but practically speaking, it's just above the scleral bed. Point number three, you don't have to stain the chariot pocket. It's a small tunnel which is very easily seen, and introducing the haptic is also very easy. So what Dr. Venkatesh was telling, that you do innovations to make life easier for surgeons. So this is something which has really made life easier for all my residents, and everybody does this technique only. And this was published in the Journal of Cataract and Refractive Surgery in the year, I think, in 2013. So this is the post-operative picture of the case. Now, the point is that if you are doing an ultra-thin DSEK or any endothelial procedure, if you are doing it as a single stage, what we found out that, sometimes you have to do these iris manipulation as well, because these are complicated scenario. You have to do, say, something like pupilloplasty, whether you use a single pass 4-throw pupilloplasty or any other technique. Then the risk of inflammation is high in the post-op period. So the risk of damage to the endothelium is there, to the host endothelium, donor endothelium is there. So we just thought that whether if we divide it into two stages, whether it will help or not. And so in one group, we did a study, and in one group, we did this intrascleral haptic fixation with explantation of the previously implanted IOL, did all the iris manipulation, etc. Waited for at least 6 weeks, and then at a second stage, we did this endothelial procedure, and we found out that I'll just skip the video for paucity of time. And we found out that the results were much better in sequential. So this was one study, a thesis given to one of my candidates, Hannah Shiney. She did all the procedures, and this was my idea to do a comparative study of Descemet stripping automated endothelial clitoroplasty with intrascleral haptic fixated intraocular lens in a sequential versus simultaneous approach. And we found out that the sequential approach had a better visual outcome on better graft survival. So this is something which I would like to emphasize. And if the scar is a bit thick, although this scar is not that much, it may require a DSEK, but this is a surgery, a video which is an old video. So, but if you have a central scar, in that case, you can perform all these procedures with the full thickness graft. Now, when you are doing a full thickness graft, once you cut the donor lenticule, you can either fix the IOL first and then go ahead with the keratoplasty, or you can just you can put the graft, put 4 sutures, and then go ahead and fix the lens. So I am not able to push it forward. Maybe just you'll have to have the patience. So the procedure is the same. The groove is created in a similar fashion as was mentioned in the study, and then a full thickness graft is being done after creating the groove, because the groove etc. has to be done when the pressure of the eye is well built up, and then you open it. So if the IOP is, if there was a very reasonable good hypotony in the preoperative condition, then in that case you can do an open sky fixation of the IOL. You can place the IOL because it is very easy, and you will not damage the endothelium of the donor tissue also by any means. So you can do it, go ahead and perform. But if you feel that there is some extra positive pressure, in that case it is always better to put 4 sutures, put the graft, and then you can maybe cut the top suture and then go ahead and fix it up and complete the procedure. So, and this is the post-operative study and the post-operative treatment. And this is one study wherein we showed, we presented in Journal of Cataract and Refractive Surgery, wherein SFIOL, SFIOL or glued IOL with DSEC and PK, both was performed and both was reported in this particular study. And this is the post-operative picture. And I just wanted to show you one thing that, I have done with suture technique also. But when I did the suture technique with the UBM, the lens was moving quite a lot. But here you can see the lens is absolutely sturdy. This is what Dr. Avnindra was telling, that the pseudophacodenesis is absolutely negligible when you do an intrascleral haptic fixation or the glued IOL technique. So this is what I wanted to show, that by UBM, that the patient is moving the eye. You can see the section is changing, but the IOL is rock solid, sturdy in its position. So that is something which I wanted to emphasize. So what I would like to conclude by saying that this is combination of the endothelial keratoplasty with glued IOL technique is a feasible technique. The IOL remains stable. You do all the procedure, the IOL doesn't move. It remains stable in its position, even in the post-op as well as the intra-op procedure. And there is no significant chance of IOL-related graft endothelial damage as well. And as I showed that the latest study, which has been published in June 2021, that if we do a sequential procedure, then the graft survival is even better than a combined procedure. So thank you very much for your patient listening. And I will be happy to discuss and have questions.